So I'm Kurt Michael. I work as the Senior Clinical Director of the Jed Foundation. And what I hope to do today is to talk, practically speaking, how do we maybe have a chance at reducing suicide rates from the vantage point of addressing the issue of firearms. So that's going to be my hope today. And so just to give you a brief introduction, I have a lot of roles, the main one being at the Jed Foundation. I want to tell you a quick story about how I came to join the Jed Foundation. So I didn't really know much about the foundation until about 2017. And I was attending a behavioral health convening in Chapel Hill and heard a talk from Nancy Roy, our current Chief Clinical Officer, who really, compelled me to learn more. And so I began to reach out to folks at Jed, including I had conversations with the co-founder of the foundation by a man named Phil Satow. So Phil is the father of Jed. And so Phil and Donna Satow started the foundation, I think as Tony pointed out, in the year 2000. So we've been around for 25 years. And it really kind of struck me how powerful this foundation was, its development through loss, right? And so we have a phrase in postvention called postvention is prevention. And one of the things that really moved me to really give up a full distinguished professor position at Appalachian State was the Satow's commitment to the mission of preventing suicide. And though all of these roles are kind of distinct, they're actually all in line with my main hope, which is to continue to live that mission basically through the inspiration of someone's grief and healing and recovery. So let me tell you some more stories about how this kind of comes together and how we've come to the point of really focusing on reducing access to lethal means. So here's the Jed comprehensive model. Again, Tony talked about it a little bit. Here's what it looks like. There's a lot of upstream elements to the foundation, but also downstream. And my day-to-day focuses on basically four things: suicide risk detection, intervention specifically designed to treat folks who become suicidal, something called CALM, which stands for Counseling on Access to Lethal Means, and what I previously mentioned, the work in postvention. So that's my day-to-day. And so again, this is going to be some sobering information I'm going to share with you in a minute. And I want to start by saying, by the end of today, 134 people will die by suicide today. It's a very heavy topic. And I just want to remind you all to do what's necessary to practice self-care. And so let's get into the information. Wanted to give you a minute to look at that slide. So if you look at that blue line, that tells us that suicide has been a problem for a long time. For 21 of the last 22 years, the rates have increased, with one exception, in 2020. A lot of folks, when they see this, and I think Ryan's going to talk about this in a minute, that a lot of people assume that homicide exceeds suicide. But I think you'll see here that suicide's long been a problem we need to address. And so again, we need to get better at this. And my belief, if we look at particular communities that are even more hard hit with the problem of suicide, Those are the rates for American Indian Alaska Native. So as much as it's daunting to see those rates climb, it's even more daunting for certain groups of folks, and that's just one example. I think Sabrina showed this slide yesterday. So where we are, where we live, where I grew up, I went to grad school about 3 hours south of here. I grew up about 7 hours from here in Colorado. And so for all of my life, I've been blessed to be in this region. As we've talked about, it's blissful, it's beautiful, it's also has significant problems. And even when I briefly spent some time in other states, whether it's Virginia or North Carolina, though it's not obvious here, where I spent about 23 years of my career as a professor at Appalachian State, though it's not obvious, in Western North Carolina, the rates look like where we are now. And so we've had to have been prepared to address this reality. So let's talk about rurality. So we know that, again, if you just on average take the suicide rates in the nation, if you live in a rural community, regardless of your gender, that rate is going to be double in a rural community, especially in the Rocky Mountain West and Alaska. Now, if we were in South Korea, this might seem like a diversion, but let me sort of begin the discussion about why means matter, right? If I'm in South Korea and I'm a psychologist, the biggest challenge for me is to address the most common method of attempt and death. And if that's true for you, where you work, 56 to 70% of suicide attempts and deaths are from jumping from a height. So it begs the question, why is that the case? There's lots of high places in the United States to jump. Why is it so much more of a problem in South Korea? It's not just a question of physical accessibility. It's a question of psychological accessibility, a term you may not be familiar with. And what I'd like to urge you to think is that what that might suggest is that even if you have physical access to something, whether you have psychological access depends on what you find to be acceptable in your own mind about what you would try to do if you were to become suicidal. Making it more complicated in South Korea is the fact that that method is dramatized in youth literature, right? Amplified even. Now, for us, that challenge is firearms. If you think about that accessibility construct I just mentioned, more kids not only report having better access to firearms, let's say, but they also see it as a viable way to make an attempt. And for rural Wyoming, a frontier state, if you collect information on the number of deaths that take place in that 5-year span between 2018 and 2022, of the 128 suicides in Wyoming, 100 were by firearm. And so again, is that true in Utah, Colorado? Yes, it's more common than overall, but what we're finding is that it's disproportionately true for folks in Wyoming. Giving you a chance to consider these two facts. If we consider the where and the how of suicide among youth, would it surprise you to know that 3/4 take place in the place of residence? And if you ask the question by firearms, where do they come from? They're household guns, right? So knowing those two facts, we have to be prepared with that reality that we have to address these two facts, right? That's especially true when we're doing things to work in schools. And so, again, going back to App State, what I did since I was there when I was a brand new assistant professor in 1999 as I traveled to rural Ashe County, North Carolina, and was given the opportunity to survey students who told me and my team just how much of an issue suicidal thoughts and behaviors were. Problem was, they had been sort of taught to kind of grin and bear it, to bootstrap it, to not necessarily talk about it, because in terms of what was available to them for treatment, they really didn't have access to treatment like you would want, right? And so we began to build embedded school mental health clinics. And I think probably the most important innovation we discovered was we tried to make it possible where access to care didn't depend on your ability to pay. And so what we did as part of this university operation was we began to develop these partnerships between the university that was in charge of training the workforce and provide those services free of charge to the students. You still had to pay for the treatment, just not the families and the young people that needed the service. So the innovation, I would argue, is to basically create a workforce of graduate students across the disciplines that we know are effective at solving this issue: social workers, school psychologists, counselors, clinical psychologists, marriage and family therapists, that while they were being trained as part of the programs at App State, they then, in exchange for supervision and training, provided that service under supervision. So we were able to sustain a lot of these programs based on this rather creative way to fund the work itself, right? And so this was the beginning. And one of the things became clear is that as much as we could be effective at reducing psychological symptoms from a clinical level to a non-clinical level, where we continued to struggle was being very deliberate about our capacity to treat suicidality. So we had to get better. And this is one particular set of slides, or a set of data, I should say, that shows basically just how prevalent in one particular school suicidality was. These are, I would say, 98% kids who were referred for risk for suicide. And we had, again, 6 years of data. And I'll just point out in year 2013-14, we had a total of 68 separate crises. And one of the people in the audience, Dr. Ann Stevens, if she can raise her hand, if she's still here. There's Ann. Ann was actually one of my graduate students who was serving these students, and we're happy to say that she now runs the psychology clinic at the University of Wyoming. So thank goodness for Dr. Stevens. But again, and I guess it's an example of how you can create a workforce that's trained and capable at addressing this particular problem. Now, we still had to get better. There's Ann's name in lights. We still had to get better. So what we had to really pivot to is a more deliberate focus on reducing access to lethal means, because a lot of those families in rural North Carolina were gun owners. And although I didn't include this on my opening slide, I just want to say to you, as much as this may seem like an odd connection, I am myself a lifelong gun owner, shooting sports enthusiast. And so a lot of people think those are kind of strange bedfellows. Can you be a psychologist and a gun owner at the same time? I would argue, yeah, you can be. And so really what we had to do is get especially good at addressing these realities, right? And so we've expanded this to include interventions across the country, in tribal communities, where we implement these very practical things around lethal means reduction. We also wrote about this. So this is a handbook of rural school mental health that came out in 2017 that really summarizes how to set up this framework with I guess, a watchful eye on the need to create that workforce and to sustain that workforce. And so I encourage you, this is a 23-chapter handbook that has contributions from 73 authors from across the globe. And so again, I don't know if any of you have plans to stick around for tomorrow, but if you did, this is what you're going to be learning tomorrow, if you don't already know this. So a very specific way that we know is effective at reducing access to lethal means is CALM. CALM was the brainchild of Kathy Barber and Elaine Frank, and also a guy named Mark Sioka, who came together with the reality that many of their patients, when suicidal, were at much higher risk for suicide if they didn't address the issue of guns, right? And so what's the objective? What are we trying to do? On my opening slide, I said, secure storage of all firearms. If you look at interventions designed to address the potential for gun suicide, even the idea of a single gun lock sounds like a good idea. But when you're regularly talking to families that have anywhere between 8 and 15 firearms per home, a single gun lock is not going to do the trick. So the objective is to be persuasive in a collaborative way to have people store all of their firearms securely. And I'll get into why that's so important here in a minute. So why do we focus on maybe a less likely means, medications? It's also the leading method of attempt. So behaviorally, this is really our hope to reduce access to firearms, medications, and anything else the patient discloses as risking their life. And of course, the last two things, follow-up and suicide-focused care. So again, what do we do when we talk about families that have a self-defense firearm, which is not uncommon? We talk about ways they want to store that firearm in a way that still provides easy access, but not to folks at risk for suicide. So you can have it, I think, at least a balance of both ways. And so this is what we often like to talk about, is having conversations about long guns and shotguns and hunting rifles, and then making sure you have a separate conversation about the self-defense firearm. And why do we do that? We do that because if you generally survey clinicians, talking about firearms is not really in their wheelhouse, on average. And so we've asked, how do we know this? Because we've asked them. And you can see that only when the patient says they're suicidal the day of the visit and a gun in the plan, even then, only 6 out of 10 endeavor to ask about gun access. We need to change that equation. And we do it in a certain way. This is not about having a conflicted conversation with or taking issue with gun ownership. This is about emphasizing safety, collaboration, choice, and temporariness. I think now in the toolkit of clinicians is the fact that if you encounter a patient with imminent risk, do you take extra steps to ensure that those firearms are stored safely? Yeah, but you don't start there. I guess my point is that yes, we have extreme risk protection orders for things that come up, potentially abuse, domestic violence, that need to be handled appropriately. But again, my urging to you is to always begin with the notion of temporary and voluntary, right? And I would argue that most of the time that I'm doing this work, you'll get agreement. I'll just give you one quick case example. And I sometimes talk about this in my CALM training, but I'll talk about it now because I think it illustrates a lot of what I'm trying to persuade you to think about. So I had a 17-year-old who was suicidal, pretty much a long-standing family that tradition was hunting, gun ownership, shooting sports. The dad viewed his self-defense firearm as being very protective of his family, right? And in fact, he felt like it was necessary to keep his Glock 17. If you know anything about Glock 17s, they don't really have a safety in the traditional sense. The safety is essentially the trigger. But he was so concerned about family safety, he actually had a round in the chamber. So I don't know about you, but if I'm startled awake, and by the way, he kept his Glock 17 under his pillow, right? So here I'm faced with this very awkward decision. Do I escalate the conversation to where I'm trying to take his gun away, which I guess I could make the case I could do, or do I continue to have a conversation to see if I can't be persuasive in having a different way to store it? And so, yeah, it was daunting, difficult. And where I started was, look, tell me what it is that you're concerned about. Tell me about your traditions. Tell me about your concerns. And he just began to tell me a series of stories. And where we eventually landed, at first he thought I was a proxy for the government. The guy, he actually said to me, "You clearly work for the FBI, Kurt." And I don't work for the FBI. But I did say, look, I said, your son knows where the Glock is, right? Yes. Does your son know how to operate that firearm? Yes. Does he know that there's a round in the chamber? Yes. Okay, so what if you were startled awake at night and it was him coming in to ask you for help and you inadvertently, because maybe you're disoriented, you just wake up and you unintentionally shoot your son? And it was a pretty blunt thing for me to say. And he thought for a minute. And then I think eventually he began to realize, actually, it wasn't just a measure of self-protection. It was a measure that actually put his own son at risk. And then something really interesting happened. He began to disclose his own mental health struggle, right? And so not only did he unchamber the round, he actually was willing at that first appointment to put the firearm across the bedroom in a box in a drawer, right? That way, if he still needed access to it, he could get access to it. Now, it took me some time to convince him. I think I still have that. Hopefully that slide will come back up. I eventually was able to convince him, instead of putting that firearm with a clip in it under his pillow, I eventually convinced him maybe a quick access push-button safe would be an answer. And he eventually agreed. So again, could I have made a decision to try to confiscate that firearm, or firearms in this case? I suppose I could have. But clinical practice, practicing ethically, also tells us that if we can come up with a plan for safety, that there's agreement and you can have a series of conversations, you have a better chance for that to be a voluntary and temporary solution that doesn't become adversarial. And so again, I think something like a calm intervention would be what we would basically want to do with people in that situation. They want to have, they don't want to have their firearms out of the home. And so again, there's some very stringent protocols that we would want to implement with families like that. And here's just one example. So Collaborative Assessment and Management of Suicidality actually partnered with the CALM team to produce a pretty stringent protocol on how to do this work. And we are beta testing this in a couple of randomized controlled trials as we speak. And I think I want to go back to what was said earlier about Utah, that in Utah public schools, they actually have legislation that's now law that if a student in K-12 comes up on referral for suicide risk, potential concerns about abuse, or that they're being bullied, that family is to receive educative information on how to store those firearms and those meds securely. And so we now have policy support to do this work, thank goodness. And I think Utah probably leads the nation in this kind of innovative thinking, I would have to say. And so Intermountain Healthcare has a particular handout that you would hand to a family. So that way they don't think that you're coming out of the blue with something. You're able to explain sort of the rationale for this approach. And again, the Jed Foundation actually was helpful in coming up with the handouts that the state of Utah uses for medication safety. And so those are two very tangible examples of how we implement very practical, specific interventions to address the problem of firearm suicide, and for that matter, suicide in general, with a focus on reducing access to lethal means. And I'll just say one more thing about some of the work that we're doing, and then I'm going to have some panelists come up and talk about this work in more detail. So in rural southern Utah, they have a particular problem, as I mentioned earlier, with suicide. And this is an example of innovating in a way that not only addresses the lethal means of suicide, but also provides an opportunity to highlight highly customized traditional tribal practices in the delivery of this service. And so I'm happy to send you a copy of this paper if you want to see a really innovative approach and a pretty highly stressed community that's been dealing with this crisis of suicide for many, many years. So I encourage you to take a look at that paper at some point. So I guess what I would say before I bring up my folks to talk more about this is that I would always want to suggest that you use things that have been empirically tested and found to be helpful for folks who are suicidal. I would urge you to consider the importance of training clinicians, even if you're not a gun owner, how to talk about firearms. Why? Because of the rates I just showed you, specifically in Wyoming. And for that matter, it's the leading method of suicide death in the United States. And do these other things I'm recommending: medications, other particular methods the patient discloses, and consider a comprehensive approach to suicide prevention that includes all of those various elements. So I'm going to take a pause, invite my panelists to come up on stage, and we'll continue this conversation in those comfy chairs over there.